Good afternoon, everyone. Thanks for spending your Saturday afternoon with us. I'm Dr. Lin Wei-Chin from the National University Heart Centre, Singapore. I will be chairing this first lecture series, first episode of the lecture series on cardiac amyloidosis. This lecture series is organized by the Singapore Cardiac Society and supported by Pfizer. Today, we'll be covering the basics of cardiac amyloidosis. We have four speakers for this first episode of the lecture series. Before we start, some housekeeping announcements for Singapore registered healthcare professionals. CME points will be submitted for attendees who are here throughout the whole duration. And at the end of the whole thing, there will be a QR code for attendees to scan to do a survey and get a certificate of attendance. The Q&A session will be at the end of all four lectures. In between lectures, there will not be any Q&A. So please submit your questions using the Q&A function of Zoom, and we will have a 15 to 20-minute Q&A session towards the end of at the end of the four presentations. So today we have four lectures by four experts in the field of cardiac amyloidosis. We'll start off by myself. I'll be talking about epidemiology of cardiac amyloidosis. Lecture 2 will be by Dr. Lim Yok Ching on the genetic basis of amyloidosis. Lecture 3, Dr. K. Evangelista will be talking to us about clinical features and red flags of cardiac amyloidosis. And lecture 4, Dr. Derek Lee will tell us how to diagnose cardiac amyloidosis, following which we will open up the floor for some question and answers using the Q&A function I mentioned just now. So I shall start off the first lecture. We will be first learning about cardiac amyloidosis, know about this condition, the epidemiology, and some basics of clinical manifestations. Just a very brief overview of this condition and why is it even a concern for healthcare professionals and cardiologists like myself. These are my disclosures. So today we're going to talk about in my lecture, what is cardiac amyloidosis, the different subtypes of cardiac amyloidosis. We must first learn to speak the same language. Then we will try to understand the epidemiology of cardiac amyloidosis in specific ATTR-CM transthyretin subtype. What do we know about this so-called rare condition? Is it even that rare in our clinical practice? And I'll touch a little bit on the clinical manifestations of ATTR-CM. So before we even dive into these conditions, not everyone has seen a patient with cardiac amyloidosis. So we need to start from the very basic. What exactly are we talking about when we say cardiac amyloidosis? So what is amyloidosis even? So amyloidosis is a group of conditions which are considered pretty rare. It's a protein misfolding disorder where native proteins in our body, for some reason or another, misfold into unstable monomers. And these monomers then self-aggregate to form this huge, insoluble beta-pleated sheet of amyloid fibrils. These fibrils will then go to end organs and deposit there where it will not be removed. And with over time, more deposition of all these fibrils, there will be eventual end organ dysfunction. So these end organs can be anything from the brain, from the heart, to the kidneys, liver, eye, really anything. And we have so far identified more than 20 proteins that can be misfolded into amyloid proteins. And these proteins are listed on the left. They can come from any part of they can affect many parts of the body. But luckily for us, because cardiologists are pretty simple people, only two kinds of proteins causing amyloidosis are of concern to cardiologists. More than 98% of amyloid deposition in the heart is caused by two proteins, light chain proteins, which are immunoglobulins formed in the bone marrow, and transthyretin, which is a normal protein that has been produced in the liver. So the combination of light chain and transthyretin amyloidosis accounts for more than 98% of cases of cardiac amyloidosis. The other rarer forms of cardiac amyloidosis, such as AA amyloidosis, all these are exceedingly rare. So for all intents and purposes, when we talk about cardiac amyloidosis, we are referring to either light chain amyloidosis, AL amyloidosis, or transthyretin amyloidosis, ATTR-CM. So let's go into light chain first. As I mentioned just now, light chain amyloidosis is actually a plasma cell problem. It's a plasma cell dyscrasia where the bone marrow produces a clone of plasma cells, a monoclonal bunch of plasma cells that produces immunoglobulins indiscriminately. These immunoglobulins can dissociate, and the light chain portion of the immunoglobulin can misfold into amyloid fibrils, and these fibrils can then go into end organs and cause damage, with the heart being one of the end organs that's involved in light chain amyloidosis. Transthyretin amyloidosis, on the other hand, is produced in the liver. Transthyretin is not formed by an abnormal clone of liver cells or anything like that. In fact, transthyretin is a normal protein that's in all our bloodstream. Previously, it was known as prealbumin. So prealbumin, transthyretin, they are the same protein. Transthyretin, what does it mean? It's a transporter of thyroxine and retinoids. So it's actually a transporter protein. For some reason that is not very well known, some people have unstable transthyretin proteins that can dissociate into monomers and misfold into amyloid fibrils. The hereditary group of patients can have inherently unstable transthyretin proteins that can make them more susceptible to misfolding. So it's either a hereditary problem where there's an inherent instability of transthyretin, or secondary to degeneration. Previously, it was called senile amyloidosis, but now we tend to call it wild type or absent of mutation, wild type ATTR. So as I mentioned just now, there's a hereditary ATTR, or also known as variant ATTR, where there's a inherent DNA mutation causing a unstable transthyretin protein. This transthyretin protein can dissociate and form into transthyretin amyloidosis fibrils. This is an autosomal dominant inheritance pattern, which I'm sure Dr. Lim will cover in a later lecture. And there's a high risk of penetrance, so meaning patients with the disease, with the DNA mutation, are highly likely to get the eventual amyloidosis disease. Wild type ATTR-CM, on the other hand, is sporadic because of aging or some other external factors that we don't really understand. The transthyretin protein can misfold in the absence of mutation. It is still a disease of older men, and the sex ratio is probably about 7 or 8:1. So it's predominantly a male disease. So we know now the basic pathophysiology of transthyretin amyloidosis. How common is transthyretin amyloidosis? Or, the perennial question is, which is the more common cardiac amyloidosis that we encounter in clinical practice? So these are the questions that I will try to answer over the next few slides. Number one, which is the more common cause of cardiac amyloidosis, AL or ATTR? What is the disease prevalence? What is the ATTR disease prevalence? And what is the proportion of ATTR-CM that is hereditary? Previously, there was not much interest in this condition because it was deemed to be an elderly person's disease and is not treatable. But many things have changed over the past 5 to 10 years that has renewed interest in cardiologists, especially in the diagnosis and the treatment of ATTR-CM. So a lot of information that I'm going to present over the next few slides come from two sources. The first is the National Amyloid Center in the UK, where they have lots of information on the epidemiology and the disease progress of ATTR-CM and ALCM, and the House Registry, which is an international registry looking at ATTR-CM. So let's first look at some information or data from the National Amyloid Center in the UK. So this is the incidence of amyloidosis, cardiac amyloidosis over the years. They started collecting data from the late 1980s all the way until 2019, and this was published in the New England Journal of Medicine in 2020. They looked at the incidence of AL and ATTR-CM. The pattern that we see here is over the past few decades, there are more patients diagnosed with cardiac amyloidosis in general. The incidence of AA amyloidosis has dropped over the years because of improvement in treatment of chronic inflammatory conditions such as SLE, nephritis and things like that. So incidence of AA amyloidosis, which is very rare to start off with, has dropped over the years. Incidence of light chain amyloidosis has gone up, but so too the incidence of wild type amyloidosis. So people are getting more in tune with diagnosing cardiac amyloidosis in general because of more accessibility to echocardiogram, accessibility to cardiac MRI, and maybe even to biopsy. So over the years, amyloidosis diagnosis has increased. In the NAC cohort, there are more patients with diagnosed AL amyloidosis compared to transthyretin amyloidosis. This is a UK experience. What about hereditary versus wild type? So this is again information from the NAC. Over the years, wild type amyloidosis, because of improvement in diagnostics, have increased. Interest in this condition has also increased, causing a spike in the diagnosis incidence of this condition. But the wild type, the rate of increase is more than the hereditary ones. That is again experience from the UK. As for the information from the TAUS registry, we can see over here the contributors of the TAUS registry. TAUS means is a short for Transthyretin Amyloidosis Outcome Survey. It essentially collects information from all these participating sites on the diagnostics of ATTR-CM as well as the long-term outcomes of these patients. There are many endemic areas contributing data, mainly South America, Europe, Japan, and even Malaysia, around our region, Malaysia, they have contributed 20 patients into this TAUS registry. What we have learned from the TAUS registry is that worldwide, there's a 50-50 split of variant ATTR-CM as well as 50% of patients with wild type amyloidosis, transthyretin amyloidosis. This is because we are collecting a lot of information from endemic areas. There are some areas which are endemic for variant ATTR-CM, namely the Mediterranean regions, as well as Japan. So all this high incidence of variant places with high rates of mutation actually skews the registry towards a 50-50 mix. In other non-endemic areas, I would say maybe the incidence of wild type is slightly higher. So what is the significance of differentiating between hereditary and wild type ATTR? Well, because we need to screen the family. If we have genetic information, that will help us screen the offspring of the patient. But the hereditary, the inherited gene mutation can also help us predict the disease trajectory. Some genes are more will affect the neurological system more, and some genes will affect the cardiac system more. Worldwide, we know that the commonest gene mutations are the VAL112 isoleucine mutation, commonly seen in Black Americans, African Americans, which is a predominantly cardiac involvement mutation. And the other very common gene is the VAL30MET mutation, which is endemic in Portugal, Sweden, Japan, and it is strongly associated with neurological disease. That saying, patients with VAL30MET that they present later on in life, they actually have a predominant mixed phenotype. So the age of presentation for the same mutation can have a different phenotype, which is very, very interesting. This VAL30MET is very well studied, and we know that prognosis is good after liver transplant for the predominantly neurological disease phenotype. What about this part of the world? Well, in Taiwan, they have done very good research on the genotype of the Taiwanese patients. They analyzed many families with ATTR-CM, and they found that there is a peculiar alanine 97 serine mutation accounting for 91% of familial amyloidosis in Taiwan. This is what I term the South Chinese mutation. We do have a small cohort published in Singapore. Again, alanine 97 serine is the most common phenotype amongst patients with Chinese descent. The South Chinese genotype again, I mean. What about wild type ATTR-CM? As I said, wild type ATTR-CM is about 40% of the TAU's registry. There's a strong male predominance and is usually affecting men in the seventh decade of life, eighth decade of life, meaning in their 70s. It is likely still underdiagnosed worldwide. There are some autopsy studies published showing that in very elderly patients who did not have the diagnosis of heart failure nor amyloidosis when they were alive, 25% of these deceased patients do carry amyloid fibrils in their myocardium. So what does that mean? Is amyloidosis an inevitable stage of aging, or is it something else? I think that's a question that we still need to answer. In a Singapore context, we do have a single center study, my center, looking at 16 years of data. We have a predominantly male population where 64% of our patients were men. Amyloid coming from the bone marrow, light chain is more common in our cohort, and ATTR-CM is the other group of common amyloid, obviously, with about 40% of them wild type. Unfortunately, 25% of our patients are not defined, meaning we do not have the genotype evidence for them. Lastly, a few slides on the clinical manifestations of cardiac amyloidosis, which will be covered by my subsequent speakers. Whether you have wild type or wild type ATTR-CM, variant ATTR-CM, or light chain amyloidosis, the presentation is very varied. Of course, everyone will have some cardiac dysfunction, but the systemic manifestation will depend on whether it's light chain, whether it's a mutant ATTR, or is it a wild type condition. Dr. K, I'm sure, will elaborate more on this later on. The ECG is often the first test that we use to suspect something wrong in the heart, same for cardiac amyloidosis. This is the classic ECG that was taught in medical school, where we have small limb leads, loss of Q waves, a disproportionate short small QRS complex for the thick walls, but it is neither sensitive nor specific. This is a patient of mine with ATTR-CM, very florid disease, but you can see the QRS in the limb leads are still preserved. This is the echo of the patient, very clear ATTR-CM, and on MRI is ATTR-CM. So ECG might not be the go-to test to diagnose, definitely not. Maybe if you see some features of it, it is useful, but it is neither sensitive nor specific. We, in fact, had published an article looking at ECG in ATTR-CM. We find that low limb voltage is present only in 35% of patients, and it is more prevalent in the light chain subgroup. Pseudo-infarct pattern, meaning loss of R waves in the chest leads, is more present, about 60% of ATTR-CM. Atrial fibrillation is more common in ATTR-CM compared to light chain disease, and AV nodal block is more common in ATTR-CM as well. So these are some peculiarities that we see on ECG in patients with ATTR-CM. So in summary, we now know that amyloidosis is a disorder of protein misfolding, with the two amyloid proteins affecting the heart being transthyretin and immunoglobulin light chains. It's not a new condition, but it's still underdiagnosed and misdiagnosed. In patients with variant ATTR-CM, the genotype is closely related to the organ involvement. Various red flag signs and symptoms should raise the suspicion of cardiac amyloidosis in clinical practice. The plain ECG is, of course, useful, but it is not. It's an inadequate tool for the diagnosis of ATTR-CM. It is the first screening test, probably, but if you suspect ATTR-CM, we should go ahead with more advanced forms of imaging. And with that, I would like to thank my heart failure and cardiomyopathy team members who are helping me take care of these very, very complicated patients. Thank you very much. So for the second lecture, it's my pleasure to invite Dr. Lim Yok Ching to give us a lecture on the genetic basis of amyloidosis. Dr. Lim is a consultant cardiologist at my center, the National University Heart Centre, Singapore. Her subspecialty interests include advanced heart failure mechanical support, women's heart disease, and in particular, genetic cardiomyopathies. So she is very well placed to teach us more on the genetic basis of amyloidosis. Unfortunately, she's not able to make it live today, but she has kindly recorded her lecture. So, Dr. Lim, please.
Hi, good afternoon, everyone. My name is Yok Chin, and I'm a cardiologist at the National University Heart Centre, Singapore. I will be talking about the genetic basis of amyloidosis. Amyloidosis, as you heard in the earlier talk, can be categorized into light chain amyloidosis, which is a plasma cell disorder, or transthyretin amyloidosis. Transthyretin amyloidosis can then be either inherited, and we call them hereditary transthyretin amyloidosis, or HATTR in short, or it can also be acquired, the wild-type transthyretin amyloidosis. This was also previously known as the senile type. For the next few minutes, I will be focusing on the genetic portion of the hereditary transthyretin amyloidosis. So just a little recap on transthyretin amyloidosis. The transthyretin protein is present in all of us, and it consists of 4 identical amino acid monomers that are bound together forming a tetramer. The TTR tetramer functions as a transport protein. It is produced in the liver and should circulate intact as a tetramer in the bloodstream. In patients with amyloidosis, the TTR tetramer breaks apart into monomer, which misfold and eventually form amorphous oligomers, and therefore amyloid fibrils. The amyloid fibrils then deposits in the organs in the body, especially the nerve and the heart, causing symptoms of neuropathy and cardiomyopathy. In patients with hereditary transthyretin amyloidosis, it is due to the mutation in the TTR gene which destabilizes the TTR tetramer, causing it to break apart, misfold, and hence leading to amyloidosis. In patients with wild-type transthyretin amyloidosis, the natural TTR protein becomes unstable with age, making it more likely to misfold and form amyloid fibrils that are being deposited mainly in the heart. So let's step back into our biology classes again. We all know that genes are the instruction manual of our body. It determines the color of our hair, the shape of our face, and also tells the body how to work. There are chromosomes in the nucleus in our cells, and these chromosomes are packed with the double helix DNA. Genes are short segments in the DNA that codes for a sequence of amino acids, which combines to form a specific product such as protein. As we recall, there are 4 bases in the DNA: the adenine, cytosine, guanine, and thymine. Any changes in any of the nucleotide bases can lead to a different amino acid being coded, and hence affecting the function and structure of the protein. The 3 nucleotide bases codes for 1 amino acid. Although there are about 500 amino acids that have been identified in nature, we only have 20 amino acids in our human body. And the different sequences of the amino acid leads to different proteins being formed. The table on the right hand side shows the 20 amino acids in our body and the short forms we use for them. Valine, for example, can be identified as VAL, VAL, or just V. So I'm sure that almost all of us at some point of time in our life play building block. So let's use this as an analogy. Imagine the gene is like the instruction manual on how to build the intended toy car, and there are steps in the instruction manuals, and each step is like a nucleotide base. If there are any printing mistake in any of the steps, the intended product might turn out different from what was intended. In human, such changes in the gene can lead to defects such as unstable transthyretin tetramer, which will eventually cause transthyretin amyloidosis. Human cells normally contain 46 chromosomes, or 23 pairs of chromosomes, 1 set each from each parent. 22 pairs of these chromosomes are called autosomes, and they look exactly the same in both male and female. The last pair, also known as sex chromosome, differs between male and female. So male has 1 copy of an X and 1 copy of the Y chromosome, while female has 2 copies of the X chromosome. The transthyretin gene is located in the long arm of chromosome 18. As we can see here, chromosome 18 is an autosome and has a mutation or variant in this gene can cause amyloidosis in both male and female equally. So we have two copies of the transthyretin gene in each of us, one from a mother and one from the father. Individuals with wild-type transthyretin amyloidosis do not have an identifiable mutation or variant on the TTR gene. Individuals with hereditary transthyretin amyloidosis has a mutation or variant in at least one of the TTR gene. So if there is only one of the two TTR gene that has the variant, the individual is heterozygous for the TTR gene variants. There are also individuals, although uncommon, who has both copies of the variant TTR gene, and they are found to have more severe clinical course of the disease with earlier onset of symptoms and more widespread amyloid depositions around the body. Before we proceed further, there are a few terms that I would like to clarify. When we refer to someone as a proband, that individual is actually the index patient or the first patient that has been identified having the condition. Variant is the new term for mutation, although we still do use it interchangeably. One other important thing to note of is that if we look into the literature, there will be various different ways of reporting the TTR variant. For example, the valine 50-methionine, Val50-Met can also be written as V50M and is actually exactly the same thing as Val30-Met or V30M. This is because in some literature, they include the first 20 amino acid in front of the sequence. So Val50-Met basically means that at position 50 of the string of amino acids, instead of valine, there is a methionine. The TTR gene consists of more than 40,000 bases. Any changes in any of these nucleotide bases can potentially lead to the formation of insoluble amyloid fibrils. There are more than 100 human TTR variants that has been identified, with the valine 50-methionine variant being the most common variant worldwide, while the valine 140 isoleucine is more commonly found in individuals with West African ancestry. So how about in Southeast Asia? So unfortunately, the literature on the type of mutation in the TTR gene in Asian countries are not as commonly found and is usually case series. So this is a study that was conducted by a group in the National Neuroscience Institute in Singapore on 29 patients from different races with hereditary transthyretin amyloidosis. In this study, they found that the majority of the patients with the hereditary transthyretin amyloidosis in Singapore carries the alanine 117 serine variant. There are also other variants detected, including the Val50-Met variant. This study reported that neuropathy is the most common initial presentation, followed by carpal tunnel syndrome, autonomic dysfunction, and lastly, cardiac involvement. Hereditary transthyretin amyloidosis is an autosomal dominant condition, which means that the individual will only require one abnormal copy of the TTR gene to cause transthyretin amyloidosis. And as mentioned earlier, the individuals that carry two abnormal copies of the TTR gene or homozygous for the TTR variant, they do develop more severe symptoms and at an earlier age. The autosomal dominant inheritance of transthyretin amyloidosis means that each child of the proband will have a 50% chance of inheriting it. As we have seen earlier, the TTR gene is located on the long arm of chromosome 18, which is not a sex gene, and hence both male and female children of the proband are at equal risk of inheriting the variant TTR gene. We do get asked at times, if a child of a proband who does not carry the variant TTR gene, will their children inherit amyloidosis from the grandparent, who is the proband? And the answer is no, as autosomal dominant conditions do not tend to skip generation. So if we have a look at the family tree here, the proband has 3 children, A, B, and C. A was unfortunate to inherit the variant TTR gene from her father and went on to develop symptoms from amyloidosis. A also passed it on to the son, D. The proband's younger son, C, was not found to carry the variant TTR gene, and hence his children F and G will not have the proven variant TTR gene, assuming their mother does not carry any variant TTR gene. So in hereditary transthyretin amyloidosis, we do see genetic and clinical heterogeneity. So variable expression means the type and severity of the disease can vary widely even within the same family. Incomplete penetrance means that some pathogenic variant carrier may remain unaffected during their entire life. And certainly, the rate of phenotypic conversion does increase over time. So what does this mean? This means that even in family members with the same variant, not all will develop clinical disease, and this is called incomplete penetrance. And among those who do, the onset of disease, the symptoms and severity of the disease may be different, and this is called variable expressivity. So transthyretin amyloidosis is still considered a rare disease, but we can see from this table that some of the variants do have quite high penetrance, which means that most of the people who carries that specific variant TTR gene will at some point of time develop symptoms related to the abnormal fibril deposition, more so as they ages. Some other variants do have a lower rate of penetrance. We also have to remember that the rate of phenotypic conversion increases with age in hereditary transthyretin amyloidosis, which means that the older these individuals are, the more likely they are to develop symptoms. However, not every individual who are heterozygous for the TTR variant will develop amyloidosis, and there will be some who remain free from the condition throughout their life, even in old age. So let's take for example, the valine 50 methionine variant, which is the most common variant worldwide and hence the most studied. Overall, it does have a rather high penetrance. However, it is also dependent on the different region, ethnic group, and age. So the risk of an individual who are heterozygous for the Val50 MET variant developing symptoms due to amyloidosis is about 91% in Portugal and much less in France and Sweden. On the other hand, the valine 140 isoleucine variant is found in about 3 to 4% of the African Americans, and this individual carrying this variant typically develop late onset cardiac conditions. Transthyretin amyloidosis also exhibits variable expressivity, which means that individuals with the same TTR variant can experience different symptoms, where some may present with leg numbness, while another family member carrying the same variant can present with heart failure. So certain variants, as you can see on the left side of the slide, such as the Val50 MET again, typically resulted in polyneuropathy, while some others, especially on the right side of the slide, for example, the valine 140 isoleucine variant, manifest predominantly with cardiomyopathy and heart failure. Most individuals with hereditary transthyretin amyloidosis do have both neurologic and cardiac features, although to a different degree of severity. Individuals with wild-type transthyretin amyloidosis, however, presents predominantly with cardiac features and is actually the most common cause of cardiac amyloidosis worldwide. So why do we do genetic testing in individuals diagnosed with transthyretin amyloidosis? Well, genetic testing is the most definitive way of identifying if the individual has hereditary or wild-type transthyretin amyloidosis. So tissue biopsy or endomyocardial biopsy samples that are sent for mass spec testing can sometimes provide a hint if the individual has the hereditary form or the wild-type form, but of course it is not as definitive as genetic testing. So knowing the specific variant in the TTR gene also helps to determine the predominant symptoms and hence referral to the correct specialist. For example, the individual with Val50 MET variant would be more likely to have symptoms caused by neuropathy, while cardiac manifestations are more common in those with the Val114 leucine variant. In our institution, we work very closely with our neurologist colleague, and hence all patients with transthyretin amyloidosis do see both a neurologist and a cardiologist. Knowing the specific variants that runs in the family is also helpful in educating the at-risk relative of the proband so that they will know what to look out for, what symptoms to look out for. And of course, we want them to identify the symptoms early so that we can treat them early. So the guidelines recommend screening of asymptomatic individuals who carry the pathogenic or likely pathogenic TTR variant 10 years before the age of onset of symptoms of the proband. In general, siblings of probands are usually older than the children and hence are more at risk of developing the condition compared to children of the proband. So some individuals might also want to know their genetic status for family planning purposes. In individual who carries the pathogenic TTR variant, IVF and pre-implantation genetic testing may be available in some countries to ensure the implanted embryo do not carry the TTR variant. Certainly, there are lots of ethical issues regarding this. Last but not least, the genetic status of the individual with transthyretin amyloidosis may be required for certain treatment options. Currently, the transthyretin gene silencer, patisiran and vutrisiran, and also inotersen are only approved by FDA for treatment of polyneuropathy in patients with hereditary transthyretin amyloidosis. There are a few clinical trials that are available at the moment, and in some of these trials, the genetic status may be required to determine eligibility for this trial. So the latest expert consensus that was published last year on the care of patients with cardiac amyloidosis do recommend that every patient who are diagnosed with transthyretin amyloidosis do undergo genetic testing for the reasons we have mentioned in the earlier slides. Unfortunately, at present, or rather in this country, the update of genetic testing in these patients are still rather low, mainly due to cost concerns and implications on the family members' insurances. We, however, do hope that sometime in the near future, with the decreasing cost of genetic testing, we may be able to get most of our patients with transthyretin amyloidosis to undergo genetic testing. And with this, I thank you.
Okay, thank you, Dr. Lim, for the very nice introduction to genetics in amyloidosis. Without further ado, let me introduce our next speaker. Our next speaker is Dr. K. Evangelista, who is a heart failure specialist from the Philippines. She is currently the chief of the section of heart failure and cardiomyopathy at the University of the Philippines, Philippines General Hospital, and the faculty of the College of Medicine of the De La Salle Health Sciences Institute. Her interests include heart failure, cardiomyopathies, hemodynamics, clinical trials, and I'm proud to say that she is a graduate of our institution's heart failure program. So, Dr. Evangelista, please.
Thank you, Dr. Wichin, for that kind introduction and for inviting me to be part of this cardiac amyloid series. So I will be discussing about the clinical features of amyloidosis and the red flags. So what do we need to watch out for? Knowing that we consider amyloid as a rare condition, but is it really rare? I would like to start off with this case. So this is a 68-year-old male who came into your clinic and he complains of progressive exertional dyspnea, palpitations, dizziness, and pedal edema. He is a known hypertensive since he was 40 years old and was on amlodipine and perindopril, but he is now complaining that his blood pressure is now on the low side at 90/60. He claims to have a history of carpal tunnel syndrome and neuropathy of the lower extremities. So this is quite common. We usually see this in our patients in the clinic. So for these patients, do we really need to consider the diagnosis of cardiac amyloidosis? Okay, wait. Okay, yeah. Sorry, my screen is, okay, yes. So these are the clinical manifestations of cardiac amyloidosis. As you can see, it doesn't only affect the heart, but it can also affect the muscles, the bones, the nerves, and it can also cause autonomic dysfunction. So we will be going through this each one by one. So what are the cardiac manifestation of amyloidosis? Your patients can present with heart failure symptoms. The patients can present with easy fatigability, and you need to look into if the patient has a family history of heart failure. You ask if there is a history in the parents, if any of the relatives have heart failure. If the patient experiences fatigue, and now like our patient, if there is a low normal BP, if there and they had a history of hypertension, and now they can no longer tolerate their medications. They also have experience of orthostatic hypotension, and they might share with you that they have elevated biomarkers or cardiac biomarkers such as an NT-proBNP or BNP and an elevated low troponin levels, but there is no variation during follow-up. So these are the things that you need to investigate when you see these types of patients. As what Dr. Lin has mentioned earlier, ECG is one of the things that we usually do in the clinics. This is very much available, widely available. And for these patients, there is some form of variability that if you are suspecting a patient with left ventricular hypertrophy and on an X-ray, but you will notice that in the ECG, there is low voltage complexes, there is pseudonecrosis or Q waves. The patient can also have atrial fibrillation and conduction system disorder, such as AV blocks and left bundle branch block or right bundle branch block. Cardiac imaging is very useful. Sometimes the patient would come to cardiologists or heart failure specialists already with a variety of cardiac examinations done. So in the 2D echo, you can see that there is thickening or restrictive cardiomyopathy. You can also see aortic stenosis for these patients. And sometimes you can also see pericardial and pleural effusion in these patients. There is an enlarged atria, and what we usually do is that we do a global longitudinal strain in which you could see an apical sparing, or what we commonly call as the cherry on top pattern. So Dr. Derek Lee will also be discussing about this diagnostics in his part of the session. So cardiac MRI is also a good tool to identify patients with cardiac amyloidosis, and the PYP scan or the technetium-based nuclear scan. I mentioned that cardiac amyloidosis can present not only as cardiac, but also as other systemic conditions such as musculoskeletal conditions. So there is this picture, what I think we still know him, a cartoon that is popular. He is Popeye. Patients with cardiac amyloidosis can have spontaneous biceps tendon rupture, but then you could see this Popeye sign. Commonly, patients with ATTR amyloidosis can also present with bilateral carpal tunnel syndrome and lumbar or cervical spinal stenosis. They can also present with hip or knee replacement and trigger finger. So as Dr. Yokching has mentioned and Dr. Lin has mentioned, evaluation of patients with amyloidosis, neurologic evaluation is very important because peripheral neuropathy and autonomic neuropathy can happen in our patients with amyloidosis. They can present with numbness in the pain or feet and inability to sense pain or temperature. They can also experience falls because of this sensory deficit. They can also have difficulty in ambulating or going up the stairs because of the neurologic effect of the amyloid and autonomic dysfunction. Sometimes we just considered orthostatic hypotension as a form of, it's like because of the patient is already very old, that is prone to orthostatic hypotension, or the patient is dehydrated. But you also need to consider, is there anything going on that I'm missing for our patients with amyloidosis, or those patients coming into your clinic just with a complaint of dizziness, palpitations, low blood pressure. Erectile dysfunction is also common for our patients with ATTR amyloidosis. Thus, it is very important that you need to refer this patient to the neurologist for proper evaluation of neurologic involvement of amyloidosis, and the neurologist can do electromyography or nerve conduction studies, which can help or support the diagnosis of amyloidosis. There are some findings that are more common in AL amyloidosis, such as nephrotic syndrome or significant proteinuria, and macroglossia or submandibular gland, as you can see here in the picture. And other findings includes periorbital purpura, which is due to the capillary fragility, and the abnormal serum kappa lambda free light chain or serum urine immunofixation, which will be later on discussed by Dr. D as part of the workup for amyloidosis. So the two slides will show you the cardiac and extracardiac red flags for patients presenting with amyloidosis. So, and the amyloidosis where it is most frequently found. Polyneuropathy, dysautonomia, deafness, bilateral carpal tunnel syndrome, ruptured biceps tendon, lumbar spinal stenosis, vitreous deposits, and a family history of amyloidosis is common for ATTR type of amyloidosis. Well, as I have mentioned earlier, renal insufficiency or proteinuria is more common on the AL type of amyloidosis. So clinical ATTR and AL amyloidosis would present with hypotension if the patient is previously hypertensive, or normal tension if the patient is on hypertensive and they can no longer tolerate their blood pressure medications. Pseudo-infarct pattern or AV conduction disease is common for all types of amyloidosis, and the levels of troponin and the levels of BNP are also helpful in the diagnosis of amyloidosis. So these are the things that we watch out for our patients that we are investigating for cardiac amyloidosis. So this is a study done in 2024 in Turkey. It included 167 patients with heart failure with preserved ejection fraction patients. And they saw that the red flags, for those patients with amyloidosis, the presence of 3 or more red flags increases the likelihood of having an ATTR. So this includes an age of more than 65 years old, ECG pattern of a pseudo-infarct or low QR voltage, and the low left ventricular global longitudinal strain pattern of the cherry on top. I think ECG is very accessible to everyone. That's why it's the more widely used diagnostic tool. But as Dr. Lin has mentioned, it's not really sensitive or specific for patients with amyloidosis. So again, this just summarizes what we need to watch out for, what we need to investigate or check on our patients if we are suspecting cardiac amyloidosis. This includes heart failure with preserved ejection fraction. As mentioned in the guidelines, the latest guidelines on HFpEF evaluation, cardiac amyloidosis is one of the mimickers of heart failure, and we need to really evaluate if it's really cardiac amyloidosis because the treatment would matter. If the patient has atrial fibrillation, if the patient has bradyarrhythmias or any conduction abnormalities, or if the patient presents with carpal tunnel syndrome, back pain or lumbar and spinal stenosis, the pop eye sign, the trigger finger, painful neuropathy of the hand and feet, and muscle weakness, difficulty walking, and falls. We also need to check for autonomic dysfunction, and this would all be red flags in evaluating our patients with cardiac amyloidosis. So going back to our patient, would you consider a diagnosis of cardiac amyloidosis for this patient? This is a 68-year-old male. He had progressive exertional dyspnea, coming in with palpitations, dizziness, and pedal edema. He can no longer tolerate his antihypertensive medication and had a history of carpal tunnel syndrome and neuropathy of the lower extremities. So if you see this patient in your clinic, so I think, yes, we need to consider and work him up to and consider the diagnosis of amyloidosis. So in summary, it is very important that we consider cardiac amyloidosis if we have patients with heart failure with preserved ejection fraction, patients with unexplained left ventricular hypertrophy, patients that were treated with heart failure medications that did not improve. And if you have these clinical presentations, the clinical presentations that I have discussed, it is very important that we educate physicians, and we need to increase the awareness on the diagnosis of amyloid, because early diagnosis, increased awareness is necessary to improve outcome so that we can initiate the treatment, because we know that amyloidosis is lethal and is a very debilitating disease. So with that, thank you very much.
Thank you, Kay, for this very enlightening talk. Our last speaker is Dr. Derek Lee. Derek is a heart failure cardiologist in the Queen Elizabeth Hospital, Hong Kong, and a visiting specialist in Clinical Genetics Service, Hong Kong Children's Hospital. He is board certified in cardiology and advanced internal medicine. His clinical and research interests include heart failure, inherited cardiac conditions, and inherited cardiomyopathies. He's going to talk to us about the diagnosis of cardiac amyloidosis, which is a very important segment that everyone is waiting for. Derek, please.
Okay, can you hear me well, Wei-Jin?
Yeah, very good.
Thank you. Thanks for having me. Good afternoon. I'm Derek Lee from Queen Elizabeth Hospital, Hong Kong, and thanks for having me. I'm very pleased to talk about the approach to diagnosis in this case of cardiac amyloidosis. I have nothing to declare. I think it would be really nice to go back and see where we come from, So I've included 2 case reports, almost 50 years old now. And it was a time when there are very limited non-invasive methods to look at the heart. If you want to study the LV size at the time, you probably have to go for LV ventriculogram. It was also a time when it's not easy to differentiate constrictive versus restrictive heart, whereby a portion of patients with amyloid heart, they were sent over for pericardiectomy only when their chests were open and pericardium's fine. It was actually amyloid. And it was a time when biopsy is the only way to confirm cardiac amyloidosis. And of course, there was limited knowledge about different types of amyloid and let alone the treatment options. But we've come so far in terms of understanding the disease. We know where these fibrils are produced. We know where they are going, and when we know which organs they are going to. We developed ways to look at the organs, look at the heart. Although much of these ways, frankly, is an indirect way of visualizing the effect of deposition rather than directly visualizing the amyloid fibrils. We've also known the stages of disease which very much guide us in terms of the intensity of treatment as well as monitoring. We've also come into an era with rapid expansion in terms of pharmacological options, not very far from heart failure field, whereby we have lots of new options in terms of treatment now. But endomyocardial biopsy still takes up a major part in the current diagnostic era. It is virtually 100% sensitive. You can definitely differentiate the types of amyloid you have in the organs in the heart. And here the gold standard is mass spectrometry. Immunohistochemistry is increasingly recognized as being quite unreliable, particularly with circulating light chains. But anyway, you can differentiate the type. And it's still necessary in many of the scenarios whereby you have monoclonal proteins in the blood, or you have equivocal imaging from the scintigraphy. But the question is, does biopsy give you all the information you want? And obviously, no, we want to know more. We want to know the burden of the amyloid, and we want to know the effect on the heart. We want to know whether there is systemic involvement. And when you take into account the inherent risk of biopsy, it's quite impractical to use biopsy as a screening test as well. So biopsy is still very important in terms of diagnostic approach at the moment, whereby again it is clearly indicated when there is a positive monoclonal protein to either exclude or include light chain disease, or in scenarios where you have an equivocal scintigraphy. But we've also established a safe and robust pathway for diagnosing ATTR amyloidosis using scintigraphy to obviate the need for biopsy. It is in the setting when you have a suggestive echo or CMR, whereby you get a negative monoclonal protein. And if you get positive scintigraphy at this time, which is the grade 2-3 uptake, then it's quite definitive in terms of diagnosing ATTR in this setting. If we take a step back and look at the whole diagnostic process of diagnosing cardiac amyloidosis, it's really a gathering of information, which includes the clinical red flags, which was discussed by Kay just now, the biomarker information and the imaging information. And this gathering of information culminates into a clinical probability of how likely this is going to be a case of cardiac amyloidosis, a probabilistic approach, whereby this clinical probability would guide us into whether there is a need for biopsy or how we interpret some results. Say, for example, if we get a surprisingly negative scintigraphy in certain case. So when we talk about imaging information, we rely very much on a multimodality approach. And in terms of imaging, what are we actually visualizing is the effect of deposition, whereby there is an increase in LV mass without hypertrophy, and this is key. And to be more precise and accurate, you should say LV wall thickening instead of LV hypertrophy, which is not true. And when it deposits, when the fibrils are deposited in the extracellular space, obviously we can by means of CMR techniques, we can measure the extracellular volume, whereby expansion is pointing towards the case of cardiac amyloidosis. And on top of these, certainly we want to know the functions, we want to know the hemodynamics, we want to know the burden, and to guide our treatment monitoring. Now, I would just skip these images. I believe most of us are very familiar with these classical features of cardiac amyloidosis on the echo, thickening, the sparkling myocardium. You know, if you get concomitant thickening in the RV wall, I septum is quite suggestive. It's very characteristic, and string pattern. But if you ask what is the most exclusive information, that is given by the echo and nothing else, and that would be the diastology by means of the inflow pattern as well as the tissue Doppler. Now, CMR gives you a range of exclusive information from the cine images, the structure and function. It has a really nice high resolution, you know, not limited by the echo window. You can visualize the apex to right ventricle very well. It's a gold standard for function as well. And what is key in CMR is that it gives you a unique way to visualize the myocardium. Now, CMR studies the proton alignment in the magnetic field in response to different sequences. So it is the only technique that gives you a direct visualization of the tissue character by means of studying the proton in response to sequences. So in cardiac amyloidosis is the characteristic, the character of cardiac amyloid is that there is a global increase in the native T1 values. And in terms of GAD, the classical feature would be global subendocardial involvement and as well as transmural enhancement. And as mentioned earlier on, we can measure directly the extracellular volume, whether there is expansion. And by means of these CMR techniques and sequences, we can differentiate the phenotypes of LV wall thickening and pick out cardiac amyloidosis from the others. If we take a step back and look at the GAD images in the third panel, you might have a sense that it looks a little bit different from the usual GAD images you see in other conditions, in the way that the discrimination between the blood pool and the myocardial signal is a little bit blurry or sketchy. And that is actually not because of the quality, but instead is a characteristic of amyloid. If we, especially in the TI scout sequence. Now, TI scout sequence is often used, you know, to pick out a best inversion time. So for example, we go along the inversion time here, and we select the best inversion time whereby the myocardium gets dark, and then we can enhance the difference between healthy tissues and pathological tissues, which is scars. So in the lower panel here, and it is a normal individual. The usual sequence is that the blood pool gets dark first before the myocardium, and at the very end here, that the myocardium gets dark, and this is the best time for studying the late GADs. And whereas in the case of cardiac amyloidosis, you can see that the myocardium gets dark almost at the same time as the blood pool, or even earlier than the blood pool, which is inverted. And that is one of the unique feature in the cardiac amyloidosis. And similar to what we have in echo, we can also study string pattern in CMR, whereby you can get the typical apical sparing pattern here. Now, radionuclide imaging gives you a whole body image. It's remarkably sensitive. There are different traces of technetium depending on the availability in different centers. Most centers get either 1 or 2 at most. And essentially, there are 2 ways to study the images. One way is the visual grade, which is universally adopted now, where you compare the uptick in the myocardium versus the uptick in the ribs. If they're equivalent, or if there is increase more myocardium uptake, then that's considered positive. And it has very good differential power between the ATTR and AL amyloidosis. And of course, when you consider the sensitivity and specificity, it really depends on how you interpreted images. What that means is if you include grade 1 to grade 3 altogether, then your sensitivity of picking up ATTR amyloidosis can reach as high as 99%. So you almost never miss an ATTR if you consider grade 1 to 3 together. But of course, if you want to be more specific in ATTR, then if you select grade 2 and 3 as being positive, which is currently in the guideline, then obviously, while being more specific, your sensitivity drops to 70%. I've mentioned earlier on there are two ways to study the image. The second way is semi-quantitative evaluation. Now, this is the planar images, and to be honest, it is much less commonly adopted, and many centers basically omit this part of the evaluation and primarily use the visual grade, which is the gold standard at the moment. And the issue with planar images is that one of the big thing is mistaking the tracer activity in the blood pool as a myocardium uptake. And this can actually be avoided using the SPECT and SPECT-CT approach to differentiate blood pool and myocardium. But as mentioned, this semi-quantitative evaluation has largely become optional or have been omitted in many practices. So now we mostly adopt a visual grading at around 2 to 3 hours after the tracer injection. And if you get a grade 2 or 3 uptake, that's considered positive. Now, this is a nice summary table, summarizing the strengths of different mortality. But certainly they all came with different limitations. For echo, it's always been an issue with the image quality, and it has no information about tissue characterization, whereby in the CMR, artifact is a big thing. For example, in patients with arrhythmia, with devices, although we nowadays scan a lot more patients with devices, but it still causes artifacts. And not to mention the cost and availability, is also a bit time consuming, 30 to 45 minutes a case. And the need for agents is also a concern in patients with renal impairment, which is quite common in any kind of cardiac amyloidosis patients. And bone scintigraphy, although not as costly as CMR, it is not widely available in all the centers, and it has an issue with radiation exposure. I think I have to mention this PET-CT. This is evolving in the field of cardiac amyloidosis, whereby it is the uniqueness of PET-CT here is that it is targeted imaging. So you inject a amyloid binding traces, which has a high affinity for amyloid. So in that sense, what is different from the previous modalities is that it gives you a direct visualization of amyloid burden, amyloid fibrils, and it gives you the whole body image. You can look at all the regions, you can quantify the global or regional amyloid burden in the heart and the body, and you can detect the molecular changes, which in some sense is very useful in terms of treatment monitoring as well. Although at this juncture, there has not been, a tracer that can confidently differentiate AL and ATTR at the moment. But given the strong affinity of these traces for amyloid fibrils, think about it, it would be really useful in cases such as this. This is a case from JAG paper published last year. This patient presented with heart failure symptoms. He had bilateral carpal tunnel syndrome, lumbar stenosis. It was negative for monoclonal proteins. He got a suggestive echo images, preserves systolic function, GLS down, diastolic dysfunction, and wall thickening. And a reasonable next step would be a CMR, which again and show a diffuse subendocardial late gap, which is quite characteristic. And this is exactly this it is exactly this scenario where you can get a slam dunk if you have a positive scintigraphy. So next step would be scintigraphy, but in this case, the scintigraphy came back to be equivocal. It was grade 1. Now, if we follow the diagnostic recommendation, the approach, in this case with a high pretest probability, but an equivocal scan, the next step would be to go for biopsy to confirm is a TTR, and that's what's the case. It confirmed to be a TTR cardiac amyloid. But what's interesting in this research project is that they did a PET scan at the same time, and when you inject tracers to the heart, it light up like a blaze. So if I can pull up the diagnostic algorithm again and visualize in a better way, this PET-CT, this evolving technique, it would be quite useful as in cases like this. For example, you have high pretest probability, but an equivocal scintigraphy, whereby if you run a PET scan, if it's positive, then you are very confident to go for biopsy. And if it's negative, then your suspicion of amyloid really needs to drop. But also in another sense, where it is also useful in cases whereby you get double negative. So high pretest probability, you negative for monoclonal protein, negative for scintigraphy, which is not entirely impossible given we know very much that there are multiple reports that certain forms of hereditary ATTR does give you false negative scintigraphy. For example, one of them is the most common one, the valent methionine at amino acid 30. We mentioned just now, even with overt cardiac phenotype involvement. So they do get false negative on scintigraphy. So it's not entirely impossible. And PET-CT would have a valuable role here in these cases. Okay. Now I would just skip this. I think we've gone through the keys of this, and I will also skip this comparison. Basically, not really a huge difference per se. I've asked the permission to take extra 5 minutes for this case, and thanks Kay for keeping the time so I can have extra minutes. But it is a really interesting case in the literature, and probably one of the most interesting case about cardiac amyloid. This is a 69-year-old gentleman. He had an incidental finding of raised total serum protein 2 years ago. So obviously at that time, they studied the serum protein electrophoresis and immunofixation. They found IgG kappa, and the free light chain showed, raised free kappa light chains and skewed raised kappa lambda ratio. They did a CRAP screening, which was negative, and bone marrow exam showed 10% of plasma cells. And the diagnosis at that time would be a smoldering myeloma. And when you look at the past history, he had a bilateral carpal tunnel syndrome, he had hypertension, and he had hyperlipidemia. Now, he was put on routine follow-up, and more than a year after, it was discovered that he has atrial fibrillation with spontaneous conversion back to sinus, was put on DOAC, and echo at that time, look at it, it shows moderate LV wall thickening and ejection drops to 40%. And nuclear stress test showed negative for ischemia. And this gentleman had recurrent fast atrial fibrillation, initiated carfidelo load, but was unable to tolerate any up titration. So just pause for a second here and reflect on this. Obviously, at this juncture, we all know this is going to be cardiac amyloid, isn't it? It's an amyloid webinar. But it was not suspected at this time, even after the echo, and it highlights a couple of issues. Number one, MGUS is quite common in elderly general population. Secondly, hypertension is also quite common, and that it sometimes complicates our interpretation for LV wall thickening, and sometimes it might just dismiss your suspicion for amyloid. And number three, it has been more than a year since monoclonal protein was detected. So if you don't raise the suspicion at the beginning, you might lose the suspicion after some time and lead to a delay in diagnosis. And the question here really is there a effective way whereby we can detect the cardiac involvement earlier on? And obviously the answer is yes. The use of anti-proBNP and troponin screening at the early juncture would be very helpful in prompting you to early echocardiogram and pick up the features early on before the systolic function drops to 40. And the second question is the CRAB negative reassuring enough for you not to search for other end organ involvements? Now, you may think a year or two delay is not too bad, but an untreated AL cardiac amyloidosis had a median survival of less than a year. So the message here is the delay in diagnosis of AL amyloidosis is fatal. Now, obviously, the story doesn't stop here. 4 months later, this patient developed heart failure, and the suspicion of amyloid was raised at the time. So given the monoclonal protein, they go forward for the PET biopsy, which came back to be negative. So there were nothing else at this juncture. And this gentleman had 2 more episodes of decompensation over the next 3 months. And it was quite fishy at the time. So they go on for a CMR, which showed typical features for amyloid. Ejection fraction crashed to 24%. It was quite a rapid course. And he is 7 months past, and the diagnosis has not been made yet. And the main issue here is a false reassurance from a negative PET biopsy when your pretest probability is high. So the message here is if your clinical probability was high, you should not be easily swayed away by just a normal diagnostic test if your pretest probability was really high, like this. And this case was referred to Brigham, and they had ECG typical features, and they studied the labs. The NT-proBNP was at 4,000. They repeat an echo, typical features on the echo, ejection fraction was 35. Now, this gentleman had no family history of TTR. He was under the average age for wild type TTR. It has a rapid disease course, which is in keeping with the toxicity of light chains. And obviously at this juncture, with the presence of monoclonal protein, you have the biopsy would be mandatory in making the diagnosis. And for completion, they also did the genetic testing. And what is out of expectation is they do get a novel variant in TTR. And the question becomes, what's the significance of this TTR? And to put it in a better way, is it AL amyloidosis with an unrelated variant of unknown significance in TTR? Or is it a TTR amyloidosis with unrelated smoldering myeloma? They went in for a scintigraphy scan, which shows no myocardial uptake at all, in keeping with their previous suspicion for AL. Now they went on for endomyocardial biopsy. They have abundant amyloid deposits. Immunohistochemistry typing was unrevealing, and I hope at this juncture you will realize that the gold standard would be mass spectrometry. And what they show is that a TTR amyloid is in the heart tissues. And the final diagnosis was hereditary ATTR amyloidosis. And I think the summary of the case is that it's a case of combination of plasma cell dyscrasia with TTR amyloid, and the fact that they find a novel TTR mutation, and it's also reasonable to say that the mutation that is found in TTR so far up to date, most of them are pathogenic except those super stabilizing variants, and obviously, in this case, when you find novel variant, it would be helpful to do a segregation analysis whereby you bring in the family and do a clinical screening. If they get positive phenotype, you also get them the gene test to screen for this novel gene. If they got, you had a good chance to upgrade this to a likely pathogenic variant. And in this case, it's hereditary. Obviously, it mandates family screening. You need to follow up the AMGAS. And the key here is unrelated AMGAS is not uncommon, as high as 40% in wild type, 50% in certain hereditary cohort. And again, once monoclonal protein is present, biopsy with amyloid typing is mandatory. And it is good to keep in mind that certain TTR variants might show you a false negative scintigraphy. And with that, I'm so sorry for taking more time, but thank you for having me today. So if you want more reading, here's the list. It would be very helpful if you can go through them. It is rich in knowledge here. Thank you very much.
Thank you very much for the very nice presentation on the diagnostics of amyloidosis and a very interesting case presentation. So it is a big topic over here. We have gone through a lot from the basic science of amyloidosis to the genetic basis of disease, clinical manifestations, and the diagnostic pathways. So now we have about 20 minutes for a Q&A session. Please feel free to type your question into the Q&A box, and we will have our experts on the panel to answer your questions. So there is a question from the participant over here. May I know what radiopharmaceuticals do you use for PET-CT amyloid scanning? Is it under research? Is it ready for clinical use? Do you think it will make it into the guidelines really soon? Maybe I ask Dr. Lee what's his view on this.
Yeah. So there are actually more than one, actually a couple of them, I think 4 or 5 under investigations. I'm not entirely a nuclear person, but what I understand from that is definitely evolving field. Apart from AI technology in cardiac amyloidosis, and so what is developing is that they are looking for several PET-CT agents, and some of them I don't entirely remember the name. I think it starts with an 238I or something like that, or 4 something. So I'm so sorry, I don't remember exactly the name. But there are a couple of agents that they are studying, and what's unique in PET-CT, as mentioned earlier on, is that it gives you a direct visualization of amyloid burden. This is unprecedented. You don't do it with echo, CMR, or scintigraphy, but PET scan it is a PET. The tracer that is under current study is a pan-amyloid binding. So all kinds of amyloid fibrils, these tracers had a really good affinity for them. So they are very, very sensitive for amyloid burden, whereby in terms of PET technology, you can also quantify the burden as well. I'm not sure, everyone can jump in if you have understanding or anything to add to this. But I do think that it is definitely an evolving field. Of course, moving forward, it would be really nice to have a technique whereby there is a tracer to possibly very specific for AL and one tracer very specific for TTR to even help you differentiate the types. But at the moment, I'm afraid there has not been a tracer identified to have that property at the moment. Yeah, so it's open to the floor. Everyone can just jump in and add to this if you have anything.
Yeah, I agree with Derek too. I think this is a very nice tool for diagnosis, but it could also help us if there are amyloid deposits other else in the whole body except for other than the heart. But it's a developing field, and it can also help us avoiding that doing the biopsy. Not everyone, not all centers can do biopsies, and not all centers can do the histopathology reading. So it's more of the non-invasive testing, but usually in our place, it's more of the cost that hinders the diagnostics to go further.
Yeah, just to add on to Dr. K's comment about biopsy. So we can easily train a cardiologist to do a biopsy. It's not difficult, but it is after getting the tissue, what do we do with it? Doing just immunohistochemistry, we know that it's insufficient. It is neither sensitive nor specific. Sensitivity or specificity, we are looking at 60-70%. When we are dealing with a potentially, chemotherapeutic agents which can treat AL amyloidosis, or we are looking at very expensive ATTR treatments such as tafamidis or in the future vutrisiran, inotersen, we really need to get the diagnosis, and we cannot live with sensitivity specificity of 70% even. So immunohistochemistry, while widely available in most pathology labs, they are really not good enough for us to make the diagnosis of AL versus ATTR or even something else. So the gold standard is mass spectrometry. This is not readily available in many centers. And even for Singapore, we do not have a clinical grade mass spec lab, and we have to send it over to the Mayo Clinic. The turnaround time is 2 weeks. It costs quite a significant amount of money to send it over. So biopsy, while technically it is not the most challenging thing, but interpreting it and more importantly, misinterpreting it is always a problem. And the pathologists, we have to partner with them to make sure that we know what we are looking for, and we do not stop at a funny immunohistochemistry telling you there is AA amyloidosis when the patient has no evidence of systemic inflammation. So that is something that we always need to think about. So yeah, so that is another limitation of biopsy beyond the technique of endomyocardial biopsy.
Yeah,
So
exactly. You alluded to it very well, and the issue about immunohistochemistry, I think, is a global recognition that it is getting more and more unreliable, especially in the case of circulating free light chains. So if you get a TTR amyloid in the heart, genuine TTR cardiac amyloidosis, if you're circulating light chains, these light chains tends to stick to the fibrils in the heart, and then when you try to stain it, you will get a false positive for light chains. So and the reverse is also true. There have been reports, multiple a group of patients, I think 30 to 50 patients with AL amyloidosis. And when they do immunohistochemistry, the results was quite surprising to come back as a TTR amyloid, whereby they could move on to mass spectrometry. And most of these patients actually are truly AL amyloidosis. So yeah. So I just throw back to you, and it's getting more and more unreliable. I think is a global recognition as well. Yeah.
Yes. So there's another question for Derek. Everyone was very intrigued by the case that you presented, or all the cases you presented. So there was a case, I remember very clearly, there was a patient with ATTR-CM, but the spec turned out negative. So is there any explanation for that? Let's bring us back to the famous Julian Gilmore paper. If you have ATTR-CM, it is 100% specific, 100% positive predictive value. If you do a if you do a scintigraphy, why is this case so different? Any idea?
Okay, yeah. So I would argue about 100%. Or I would just drop it down a little bit in maybe 98 to 95. I mean, scintigraphy has it's the uniqueness of scintigraphy. You have to be aware of this scenario where you use it as a specific test to obviate the need for biopsy. It is only when you have a suggestive echo CMR and negative monoclonal proteins, whereby there's a role there. And as you said, and the specificity is really high. I've also alluded earlier on, it depends on how you look at scintigraphy uptake, and it changes your sensitivity and specificity. Of course, if you include a grade 1 as well, the sensitivity shoots high. And now going back to the question, why a hereditary TTR would get a negative scintigraphy, and honestly, I think no one knows at the moment. But there has been postulation that some of the TTR, so this scintigraphy, they look at fragmented fibrils. So whereby there is high intake of calcium, so that it's shown up in the bone traces. And what we are aware that is that there are certain types of hereditary ATTR whereby the fibrils are not fragmented, but a full form of fibrils. And it is possibly that these full form fibrils, they are not easily picked up in scintigraphy. It is the fragmented form of fibrils that is being picked up in scintigraphy. So there are a couple of variants. Which was I've illustrated just now, which was quite well reported that with a TTR cardiac amyloid, but false negative scintigraphy. For example, the Val30 MET we've mentioned just now, or the serine 77 tyrene. So some couple of these variants, they have been well reported to have a false negative scintigraphy. But honestly, I think it's not definitely understood why is it there. Yeah.
That is a very good point. In fact, nobody really understands why bone scintigraphy is able to diagnose ATTR-CM, it just happens. And why is it some AL amyloidosis also turn out positive on bone scintigraphy? So there's no real, understanding about how the tracer sticks to the amyloid, it just does. And why is it specific to ATTR? We have no idea. But it's useful for us to use a non-invasive method to alleviate the need for biopsy. There is another question more on the clinical side of things, so I shall direct that to Dr. K. Should Holter monitoring be mandatory given the high prevalence of atrial fibrillation? What do you think?
Yes. Yeah. For patients that you're highly suspicious of amyloid, I think Holter monitoring is very important because, as we know, the amyloid fibrils can really deposit in the conduction system, and they can present even with blocks. So not only atrial fibrillation, they can present with high degree AV blocks, and it's very important that we catch this so that we can intervene early. If the patient goes into atrial fibrillation, we need to anticoagulate. They're very prone to having strokes. Like only the two conditions that you don't need to compute for a child's fast. If the patient have cardiac amyloidosis, you need to anticoagulate immediately. Like for hypertrophic cardiomyopathy, patients of these conditions have very high risk to develop stroke. So we have to catch this early. If your patient complains of palpitations and then you really can't catch, I think you need to do a Holter monitoring. If you really can't catch atrial fibrillation, do a loop monitoring for this type of patients.
Yeah, if I can just add a little bit more on this, I think now in this era it is becoming a more recognized, I think a very much recognized given the level of advertisement on cardiac amyloidosis. I think with such recognition, we probably should not be satisfied with just diagnosing cardiac amyloidosis, but to diagnose it at an early stage. So what I really want to bring out one of from the last case is how we try to pick up the early stage of amyloid by means of using the biomarkers and echocardiogram, which is widely available, to pick up the early stages before, once the systolic function drops, is not an early stage, definitely. Once you develop atrial fibrillation blocks, they are not early stage. So we should not be satisfied by just simply, diagnosing cardiac amyloid, but instead we should aim to diagnose it early on. Yeah.
Okay, similar in the same vein, maybe I would try to get Dr. K to answer this question. What would be your approach then to screening for screening of ATTR-CM? We are faced with a HFpEF epidemic. Everyone all the elderly patients are now developing HFpEF. Do we all suspect cardiac amyloidosis in this elderly population? What are some conditions that would make you look harder and not brush them off as run-of-the-mill HFpEF? What do you think?
Yeah, I think so. Everything goes back to a good history and physical examination. So you really need to dig deep to have a suspicion of cardiac amyloidosis for our patients. If you have a patient with LVH and the patient has been hypertensive and cannot tolerate the medication, you will be thinking, why is the patient having this condition? So you combine the clinical picture of your patient with what you see in the echo. And it's very important that you also evaluate what you see in the echo. You interpret the histology as Dr. Derek has mentioned, and we can do GLS strain for these patients, in which you can at that point have a higher suspicion if you're gonna consider cardiac amyloid. So for AF, you need to evaluate what is really the cause of atrial fibrillation. If the patient goes into the clinical setting of an elderly developing these neuropathies and having this restrictive cardiomyopathy type of finding in echo, then you could highly be suspicious of this condition for your patient. So overall, you need to combine your history, your physical exam, and your basic diagnostic screening tools for this patient for you to work this up. As what Derek has presented to us earlier, it took 8 months. And if your patient is having AL amyloid, by then your patient is about to die. So the average screening or diagnostic time for patients with amyloid runs around 1.5 years. And it's quite sad that it takes that long for us to recognize that this patient really have cardiac amyloidosis.
Yeah. If I mean, I fully agree with what you mentioned. Um, um, Equally, we also recognize that this is actually a gap, isn't it? So there are you can have suspicion, but equally you can't send every patient for biopsy and amyloid scan given the the inherent risk as well as the availability of amyloid scan. I think what we have in consensus here, I mean, we all recognize there is a gap here. We obviously we want to send all the low flow gradient. We want to send all the elderly above 65 with LV wall thickness for undergoing the screening. But it's not realistic at the moment. It's still a gap. But what I think what our consensus here is not to miss AL cardiac amyloidosis, which deteriorates rapidly, and they have a mid in is the hematological malignancy. So that is something that we cannot miss. So if you have circulating monoclonal proteins, suggestive echo and CMR, it's really you have to go for further down to the diagnostic pathway. Of course, if you are suspecting AL amyloidosis, you have different ways of biopsying the patient. You don't have to directly go at the heart. You can the fat pet biopsy gives you a really nice sensitivity of 80%. You can also biopsy from any organs you think might be involved. So it is the AL cardiac amyloidosis, this AL3 light chain disease that we don't really want to miss. Yeah.
I have to agree with that. I need to say this as I can't stress this enough. Many cardiologists still think that amyloidosis is an old person's disease. There's nothing that we can do for it. People die with the disease, they don't die because of the disease. And even if I diagnose it, our healthcare system is not rich enough to support everyone on the families. But we shouldn't shoehorn ourselves into thinking amyloidosis, you need to think about the families. We forget that AL amyloidosis is a blood cancer. You do not leave a patient with a colonic mass, undiagnosed and just leave him alone because he's going to die with the disease. That's not happening in the oncology world. We shouldn't disregard the possibility of patients with LVH, some weird, unexplained LVH. We cannot not think of light chain disease because the mortality is high and there is now effective treatment that can dramatically improve the mortality of these patients. So let me make a pitch for the next series of lectures. There will be a hematologist coming on to talk about the latest hematological treatment for light chain disease, as well as some electrophysiological issues in amyloidosis that will hopefully help us answer whether we should indiscriminately do 24-hour ECG monitors or even implant loop recorders for patients with amyloidosis. Maybe we just have time for one last question. So to Derek again. Do you have an easy to remember echo screening algorithm for patients with unexplained LVH? What should we do? What is the cutoff that you will say is significant LVH? I'm asking this because I see a few of my echo sonographer colleagues in the audience, and I'm sure in their practice they see lots of patients with LVH. Do we stop there? Do we look further? What's your advice?
Yeah. I mean, I'm a CMR person, so of course I do echo as well. Um, I mean, the study of in a patient with LV wall thickening is obviously apart from the wall thickness, you also try to look for all the features I've shown just now on the echo slide, and which is well known. But I and recently had a really interesting case, actually two interesting cases undergoing CMR. Um, One of them is I think is a gentleman at 70 years old, and he had an O infarct, O anterior infarct, whereby most of the walls are thinned. But it is really the suspicion at the basal inferior wall that it is unusually thickened, at not dramatically, not overtly in a way more than 15 millimeters, not that kind, but is 13, 14 millimeters at the age of 70s. And it is these unusual features in a patient with, with a good blood pressure control. The ECG is also quite unusual, having an unexpectedly, normal voltage given the thickness. So with gathering of this information, there is a suspicion, and afterwards the amyloid scan confirms it's a cardiac amyloidosis. So it's not exactly always a straightforward case, particularly, for example, in this case, it's an old infarct with thinned wall. I have another interesting case, if I have time, it would like to show whereby, on the four chamber cine on the CMR, you see an anomalous papillary muscles apically inserted. You have a thickened aortic valve, restricted opening of aortic valve, whereby it fulfills the severe degree of aortic stenosis, while you are also having a thickness of 15 or 16 millimeters, as I recall, while the ECG is low voltage. So you have all the features now, anomalous inserted papillary muscles, which is more inclined towards a sarcomeric hypertrophic cardiomyopathy. You have a severe aortic stenosis, which, in some way might sway you away from, going further to amyloid because it might well explain the thickness. But at the same time, the ECG makes you suspicious. So what I mean is, I don't tend to imaging is not everything, as Kate mentioned earlier on. We are clinicians, so we do have to involve the clinical information and interpret it in a clinical context, in a broader clinical context, and that would perhaps help. I don't know if I answered very well the question. I don't know, easy to remember way of going forward to study LV wall thickening and imaging. I don't know if you have good ideas. You can just pitch in. Yeah.
I think you mentioned the crux of the matter. You need to put everything together. Just dismissing something thick as a consequence of high blood pressure or as a consequence of aortic stenosis is never enough. There should be some other things that you look at. Blood pressure that is dropping over the years, inability to tolerate blood pressure medications, or in a very weird situation where you have a normal blood pressure and very thick wall. So all this should ring our alarm bells for a primary myocardial disorder rather than secondary to high blood pressure or aortic stenosis, where we like to associate with thick walls and stop investigating. So I think the key here is to never stop thinking. If you see someone with a very thick wall, think why. Is it really because he has high blood pressure? Is it really because of the aortic stenosis? Or is it something primary to the myocardium? For example, we can diagnose hypertrophic cardiomyopathy. We may not diagnose many amyloidosis in our clinical practice because it is still a relatively uncommon condition. If we want to look at our cardiomyopathy cohort, one of the more common conditions will still be hypertrophic cardiomyopathy. But there is always an overlap where there are many hypertrophic cardiomyopathy patients being diagnosed with amyloid and the other way around as well. So I think always keep an open mind, always think of the reason why the patient is having a thick heart. You can be labeled with hypertrophic cardiomyopathy for many years and in the end you turn out to be amyloidosis. I do have one patient like this. So always question the diagnosis, and if something doesn't fit, I think we should all go back and revise what we think we got for the patient's diagnosis.
Yeah.
All right, I think we are just in time.
Brilliant.
Now it's 4:40 p.m. Any last words from my panelists?
Yeah. So from me, I think we need to really increase awareness. Just what you have mentioned. In our place, in our country, actually, tafamidis is not available. So what people think is that why should I work this patients up for amyloidosis? I cannot offer this medication. The medication is very expensive. But as you have mentioned, there are implications on that and good diagnosis on getting that diagnosis for that person. And we make ways on making the medications available. Like I have a patient. I'm doing shared care with Dr. Lin for patients who needs the tafamidis. So I will be sending him the patient to Singapore to avail of the medication so that we can start the medication, and then we'll do their treatment monitoring at home. So not that shouldn't stop us from getting the right diagnosis, and offering the treatment for our patients. So we really need to increase awareness on cardiac amyloidosis and other cardiomyopathies for our patients.
And
Yeah.
I totally agree. There are more treatment modalities coming up in the future. Many molecules are being investigated, and the cost of treatment will probably get better in the future.
Yeah, I mean, I don't know if I have you know, a lot more to add. I mean, in terms of diagnosing cardiac amyloidosis, I really like the probabilistic approach. I mean, the more clinical information you gather, the higher pretest probability you have. Then next step, whatever results you get come back, and this probabilistic approach really helps you and guides you whether you drop the suspicion or not, or you still want to go forward to the next step and confirm it with another modality. So this gathering of information is really crucial stage. The more information you got, the more reassurance that gives you is likely to be amyloid. I mean, also moving forward, we also looking forward to the future in terms of the evolving PET-CT in this field, as well as the AI technologies is really amazing. Just given the clinical information, the AI would generate a lot of things here. So I think it is really exciting looking at the future as well. Yeah, I throw back to you.
I must agree with Derek. The field of amyloidosis has never been more exciting, and there are more therapeutic options, diagnostic options in the pipeline. Over the next 5 to 10 years, it's really the boom of amyloidosis treatment. So with that, I would thank everyone for your attendance. We can scan the QR code for the feedback form, and everyone who does the feedback will get a certificate of attendance. The next lecture of the series will happen in October. We will be looking at a more multidisciplinary approach to amyloidosis management. This will include our neurology colleagues, our hematology colleagues, and our electrophysiologists who will be sharing with us the multidisciplinary aspect of amyloidosis management. So with that, I thank everyone for your attendance. Have a good weekend ahead. Bye-bye.